The webinar is on the website, and we're also recording the webinar today, and the recording will be available on the website within 48 hours. I've got 2 in Central Time Zone. Those of you on the East Coast, it's already 3 o'clock. So I'm Mercedes Bern-Klug, and I'd like to welcome you to today's webinar. The topic is the POLST Paradigm in Nursing Homes. And session are on the website. Dohrmann, Nicole, Peterson, and myself, the 3 of us are working together on a project funded by the John A. Hartford Foundation Change Agents Project, and we'll be talking about that project later on today. Each of the presenters will be introduced following this section of the title slides. Also wanted to acknowledge the Retirement Research Foundation for the support in the webinar technology, and also Honoring Your Wishes, which is a community-wide advanced care planning initiative here in the Iowa City, Iowa area that has the administrative home with the Iowa City Hospice. Our area is Iowa. I just want to make sure everybody has their geography correct. We're just about in the middle of the country, and Iowa City is on the east part of Iowa. So the project that we're going to be talking about today in the city area takes place on the eastern part of the state of Iowa. We speak for about 50 minutes and leave about 15 minutes for questions and answers at the end of our session. If you have a question, please put in the Q&A box. It's the bottom right of your computer screen. And if the question is about a specific slide, it's helpful if you put the slide number down. And then the recording will be available in a couple of 48 hours. Our first speaker today will be Jane Dohrmann. Jane's a social worker. She's the director of Honoring Your Wishes, which is a community-wide advanced care planning initiative. I need my camera on anymore. She's employed by Iowa City Hospice, which is our local nonprofit hospice. She promotes a systems-wide approach to advanced care planning. She is also a Respecting Choices facilitator and instructor. And as many of you know, Respecting Choices is the program developed in Wisconsin, and that has been evidence-based to show that it's effective in helping people get the kinds of care that they would like to get. She also guides quality improvement projects related to advanced care planning. Our speaker today will be Nicole Peterson. She's a geriatric nurse practitioner, and she's on the staff of House Calls with faculty practice here at the College of Nursing at the University of Iowa. She provides primary care for people who live in long-term care facilities, and she also teaches undergraduate nursing students about aging and gerontology. And along with Jane, she too is a facilitator and an instructor for the Respecting Choices Advanced Care Planning model. I'm Bern-Klug. I'm with the School of Social Work at the University of Iowa, and I also direct the Aging Studies program for the university. My area of research is advanced chronic illness and psychosocial issues, and I'm co-founder along with Bob Conley of the National Nursing Home Social Work Network. I'm going to turn this mic over to my colleague, Jane Dohrmann. Go ahead, Jane, please.
The opportunity to be with you today. What we'll do today is discuss POLST, and we'll be present on the POLST paradigm. We'll talk about POLST is important and its prevalence throughout the United States. What makes it unique and beneficial in the nursing home setting. Talk about our specific Hartford Change Agent project and what we have to date. That program started in August of the last I'd like to talk about POLST, as in the form, and then about the POLST Paradigm. POLST are physician orders for life-sustaining treatment. It began in 1991 and turned people's health preferences into medical orders. It has been a DNR or CPR order, which is currently used in care centers, but it may be add a DNR order as well. What's really wonderful about it is that it provides a lot more choices about care. Document, it's meant to be a portable document that goes from one setting to another, and encourage people to take that document with them if they're transferred from a hospital to a nursing home or home, and for the type of care that they want, comfort care or aggressive treatment, and it's considered to be in terms of the standard care for long-term care residents across the country. Comes in any colors depending upon where you live in the United States, and the color that has been selected. So in California, it's pink. In the state of Iowa, we have salmon. And it's divided into various sections. The first being decisions related to CPR preferences and being goals of care questions for the medical intervention. To review with you today is based on the California form that became effective in here. The reason why I've selected this is it is a very person-centered form using a lot of simple language that the National POLST Task Force recognizes as one of them in the country. So the first section is called the C section related to cardiopulmonary resuscitation. To this are if a person is found and they do not have a pulse and they are not breathing, what would the differences be in that situation? Would they that CPR be attempted, and or would they prefer to allow natural death or that CPR not be attempted, known as CPR? Now, it is found with a pulse or is breathing. There are for care in the next section. If someone selected that would like CPR to be attempted, that the next box for treatment needs to be checked because that needs to be best practice in terms of CPR. That they are willing to go to the hospital and to be put in. All would be taken to long life. I'm going to comfort-focused treatment, and where their primary goal is that be maximized, but they were to receive care in their current setting and prefer not to be transferred to the hospital. Only their symptoms could not be managed in the current location. The middle in between, known as selective treatment, that they want comfort care supports to all three boxes, but would prefer not to be intubated and would prefer not to go to the ICU. They would go to the hospital if their needs cannot be met in their current location. A third is related to artificially administered nutrition, and that the process of discussing people's options. This is usually your section to complete. Not necessarily, but in general, people often opinions related to whether they would like to have artificial nutrition, including feed, if they would prefer to, would like a trial period. The fourth step is the part to help make the form legal, become legal, and in either the patient with if they have decision-making capacity or their legally recognized decision maker needs to sign the form. If a person has an advance directive, to review that and to state there is an advance directive that is referred to. I also wanted that we put the designated healthcare agent's name on the form, and then there's if they don't have, and then it would be their surrogate decision maker by default according to their respective laws of state in which you live. What needs to be completed is by the physician or it's a licensed independent provider. They sign the form, and once the form and the patient and or their legally recognized decision maker, and it becomes a legal medical order. It's common throughout the United States. In various degrees or levels has it been implemented. The POLST Paradigm Task Force has created standards of care for POLST, and at this standards of care determine to what degree different states have rated their recommendations. There can mature to no program available, and as you can see, there's only a couple of states in the country that don't have POLST, at least to some degree. States are Oregon and West Virginia, and it became an endorsed program in February of this year. And if you want POLST, I strongly encourage you to go to the POLST website at polst.org. POLST important. It is a more effective program than other advanced directive programs. And as a national quality forum, POLST more accurately conveys end-of-life preferences and high adherence to medical professionals. This is key. People are likely to be honored if they have a POLST. That is recommended for. It is not for everyone. The recommendations are that it be for people with serious life-limiting illnesses, children and adults, for elderly, and people with chronic critical illnesses who are closer to the end of life. They're more in-depth end-of-life discussions related to healthcare preferences. The clinical question asked is, would I be surprised if this person passed away in the next year? If I wouldn't be surprised, then a full discussion is appropriate. We refer to POLST as IPOST, Action Orders for Scope of Treatment, legislative process to have it become legal, and it was entered in law in 2012. If you'd like to refer to our Iowa Code chapter, it's 144C. Often, what is the difference between an advanced directive and an IPOST? I'll just show you a few key points. We recommend that every adult with decision-making capacity complete an advanced directive. Opportunity to talk about what type of care they would like in the future, the forms themselves, or in with assistance from a facilitator. They care for who want to make decisions for them if they could not communicate, who they want to be their advocate. Responsible for distributing those forms to the individual they selected as their healthcare agent for durable power of attorney for healthcare and review with their healthcare provider. An IPOST is for children and adults who are seriously ill and the frail elderly, needed of care that they want now and in the future, if they can in order. Being by the licensed independent provider and the healthcare agent or the patient, depending upon if they have decision making. Would be that's what makes POST or the POLST unique. Well, for reviewing it, the healthcare provider as well as the family. And it is also important that the individual family or care center staff present the form if there were an emergency, if EMS calls, or if there's transfer of care to the hospital. What we want, I think, throughout this presentation is that it's important to have facilitated discussions. That comes into play. We don't want the POLST to be considered a checklist, that people thoughtfully reflect on what's important to them, what their beliefs are, and as that relates to their goals of care. Who the designated healthcare agent, so that if they do need to serve in that role, to act the wishes of that individual. It's also that you involve the entire community, just people who understand it and know what to do with it. One of the POLST is that the conversation doesn't have to be started over and over and over when a person goes from one care setting to another. It explains it should be reviewed, and care the conversation. We have a community-wide collaboration and have involved EMS, hospitals, care centers. Everyone is educated about POLST and what that means. So, what is important in terms of the POLST paradigm is that people thoroughly review their options for care, that a medical is completed, regularly reviewed, because people do some change their choices. They're very normal, usually as there might be a decline, and honor people's choices. That's our responsibility as health professionals. Review when a person transfers from one care setting or care level to another, when there's substantial change in the person's health status, and when their preferences change. I'm going to hand it off to Nicole, and she'll talk about some specific scenarios in the nursing home.
POLST documents translate the patient's wishes into medical orders. That means that POLST eliminates any guesswork of what the patient wants, because their wishes are documented in an order that healthcare providers can follow. Very specific, as they allow additional requests to be written in as the resident desires. Research shown there is a high level of compliance with POLST documents at the end. POLST document care given at the end of life, 4% in fact. Additionally, DNR status does not dictate level of care. There can sometimes be an incorrect assumption that if a resident has a DNR order, that they don't want any treatment. But DNR stands for do not resuscitate, not do not treat. Advanced planning and POLST documents fill the gap and create a more comprehensive plan of care for residents at the end of life based on their own wishes. Important to note that POLST sessions that are not completed do Zoom fulfillment. Posted by all healthcare professionals. Thing to do in the middle of the night scenario. A lot of times, this can be a difficult time. Maybe the primary provider cannot be reached or normally are not available. It's helpful to know how to proceed in a situation where crises may occur. Additionally, emergency medical service members can follow the POLST orders in the field. If they respond to a call in a nursing home, they're trained to ask for the presence of an IPOST in Iowa or POLST orders. Provide emergency department staff direction with patients that they have maybe not ever met before, may not have records in their electronic systems, or a person who may be transferred who's unconscious or in an altered mental state, and there's not a family member or anybody who accompanying them that can speak for them. Iowa will honor POLST documents from other states is in accordance with our state laws. Provide clear instructions and improve communication. In the study, 75% of healthcare providers felt that POLST provided clear instructions about the patient's preferences. And in a study conducted in the nursing home setting, found that 91% of healthcare providers felt that the POLST improved communication communication of the patient's preferences between the patient and the rest of the healthcare team. Jane earlier mentioned about the role of the licensed independent practitioner. A physician's assistant and a nurse practitioner review the resident's wishes as documented on the IPOST. They do this at a regular time when they're visiting with the resident. They'll to elaborate on what the resident's goals are and give specific information on the expected disease trajectory or other chronic illnesses they may have. They need to include the resident's wishes in documentation in their own personal medical record. They view and may update the post with changes that occur in the resident's condition. Also reiterate to the patient that the IPOST can be changed at any time, especially if their condition improves or perhaps worsens. POLST is easily accessible in the time of a healthcare crisis. There's a standard procedure for where to keep the IPOST. In homes here, the IPOST is kept in a plastic sleeve in the front of the chart. It's helpful that there's one standard document in the color of sin in our state. You get the bright colored form in other states. It makes it easy to find when the person may need to travel or there is a healthcare crisis and needs to be referenced easily. For people using electronic medical records, there is a cue on the face sheet of their record to alert healthcare providers that an IPOST exists, and they can go and find it. It's important to note that actions of healthcare providers who follow on an IPOST are upheld by Iowa State Legislature. The Iowa IPOST legislation provides legal protection for healthcare providers who follow the orders as written on the IPOST. If a provider has some sort of internal ethical conflict, maybe religious or otherwise, the legislation states that they may transfer care to another provider if unwilling to carry out the wishes as identified on the IPOST. That is no liability. Also, legislation points out that death resulting from withholding or withdrawing life-sustaining procedures as following the IPOST does not constitute suicide, homicide, or dependent adult abuse. Legislation, legal language places emphasis to permit the natural process of dying. The IPOST mission is to create a system to honor the healthcare treatment choices of individuals, improved communication across the healthcare continuum, to promote community engagement in advanced care planning. As we contribute to our community's efforts to reach the mission of IPOST, we are lucky to have been chosen to receive support from the Hartford Foundation. The picture is of me, Mercedes, and Jane at the Hartford Change Agents Conference. The picture on the right is of participants in our grant project. The AIM Hartford Change Agent Project. Nursing home staff members' ability to engage residents and families in the advanced care planning process includes the POLST Paradigm. Document nursing home residents' medical care preferences in the healthcare record. To develop organization-wide protocol for securing, auditing, and following IPOST. To complete audits to ensure advanced care planning and post outcomes. We'll tell you about some of these updates on our project and things that we have been learning along the way.
And thank you, Jane, also. So at this part of the webinar, what we'd like to do is talk a little bit about what we're learning from our practice with the 2 local nursing homes that are also part of our project. First of all, I wanted to underscore that the approach that we've decided to take is a collaborative approach. And in our collaborative model, we are meeting with practitioners in the nursing home, and we're exchanging information. It's not that we're going there with the information. We're going there to facilitate the exchange of information, and we recognize that the people there in the setting, the nurses and the social workers that we're working with, have a lot of experience and practice wisdom and education, and they also have those core and key relationships with residents, family, and staff. And so we're meeting with them to share the information that we have about the POLST paradigm, social change, and then also to acknowledge and validate the desire for good practice and to kind of troubleshoot together when issues come up, and they do come up in trying to implement the POLST paradigm. There are lots of systems issues. When you look at a form, if you think that, okay, this is just a new form we're going to add to our repertoire, that's the wrong approach. And so I'd like to build on what Jane said a little bit earlier. It's called a paradigm because it includes the piece of paper, but so much more. And the conversation about what people's preferences are, but then there are many systems issues that have to be worked out, nursing home by nursing home, in order to make sure that there's clear protocol about what to do to get a post. In Iowa, we call it IPOST. So when I say IPOST, you can think POLST. To get the form completed, yes. Have those conversations occur, yes. But then also have the information stored in such a way that other people can find it when they need it. And that's both people within the nursing home and also people in the community. And those are the systems issues that we've been spending the most time with as we work with these 2 local nursing homes. And we developed that insight from Nicole's doctoral work. She focused on the implementation of IPOST in 1 nursing home in our local area, and each of the staff were trained and really highly motivated to make this work, and able to document that there were many system issues that made it difficult to have a seamless system of acknowledging IPOST and utilizing IPOST, and that's in part where we got the idea for this Hartford Change Agent proposal. And bottom line is that systems change can take time, and the devil is in the detail. But it's worth it. I'll tell you a little bit about how we're going about our Hartford Project implementation. We meet with the 2 nursing homes at their nursing home once a month. And so Nicole, Jane, and I go to their conference table and we sit down and meet with their designated social services person and their designated nurse. So each of the nursing homes in our project have appointed 2 people, a nurse and a social worker, to be the IPOST experts on site. And so we meet with them monthly to put our heads together to try to figure out how to make this really work in this particular nursing home. So we're exchanging information about the law in Iowa and what other states have experienced in terms of implementing the POLST paradigm. We're sharing recent updates in the literature. They're sharing practice wisdom. Jane and Nicole also have years of practice and are currently in practice, so there's lots of practice wisdom being exchanged across the table. And then Jane is our local project director, a program director for Honoring Your Wishes, and that's the community-wide advanced care planning program. And so this IPOST is part of a much larger effort. We're also there to bring empathy and to brainstorm with them on how to overcome some of the challenges that are being faced in the real world trying to use the POLST paradigm. And a lot of what we do is normalizing. Jane, who works with many groups in the community, has heard many of the issues before or many twists on the issues, and she's able to reassure the staff that some of the they're having with particular residents or particular families or particular staff or particular providers that this is normal, and this is part of getting used to learning a new culture, and the culture that is part of the POLST paradigm, where it's really trying to be resident-centered in making sure that we know what people's preferences are so that we can help to honor those. There's work that we do every month talking about record keeping, and by that, Jane in her Honoring Your Wishes program has developed an auditing form so that the nursing homes can keep track of how many people are eligible for an IPOST in their nursing home, and then quarterly how many people have an IPOST. And it's just a way for the staff to be affirmed that they're making progress and that things are happening and that things are changing. And then also we work with the staff in both nursing homes to train their fellow staff members. So in each particular nursing home, we met with the nurse and the social worker ahead of time. We co-developed a presentation and then for their staff, and then we co-presented it. So our Hartford group will start out the meeting and then turn it over to the local nurse and social worker who would talk about IPOST with their residents and the kind of protocol they're developing and the kinds of issues that they're seeing. So very much a collaborative model. We're also working supporting the staff to work with residents, how to talk with people about these, how to set up conversations, what's the social environment that it needs to look like to have these conversations, how to engage families, and how to engage other providers. Some of the nursing homes that we've worked with have posted information about IPOST in their newsletters and have told us that family members who read the newsletter actually bring it up with them, like, you know, I'd like to learn more about IPOST, or I think this might be something that is important for me to do. So a lot of what we're doing with our Hartford grant is providing support. As issues come up, we want to be there for the nursing home social worker and the nursing home nurse to help solidify their working relationship on IPOST-related issues, but also so that they don't feel isolated or alone. And Jane in particular gets a lot of phone calls and a lot of emails and is really good about responding promptly. And Nicole also has, as part of her actual clinical practice, going to these nursing homes to see residents anyway, and so we're able to provide a lot of support. And in doing that support, we're learning a lot about the implementation of IPOST as well. And one of the things we're learning is that it's not enough to have the IPOST form completed even with conversation. We also need to make sure that that information, the contents of that post form, make their way into the medical record. I've been working with both nursing homes to do that. And then we've also, when we meet monthly, we talk about situations that went well in their nursing home and situations that didn't work as well as they would have liked. And so for one nursing home, they told us that twice in 1 week they had families who were confused about the difference between CPR and the Hemlock method. And we're both saying, yes, 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 we want CPR for our loved one because even though we know she may be approaching the end of her life, we don't want to die by choking. And so if she's choking, we want to make sure she gets CPR. And that was a teachable moment. So the staff was able to sit down with the family and talk about, okay, this is what CPR is, and explain what CPR is, explain the procedures, and then also talk about the circumstances under which CPR is most effective, and then to distinguish that from the kind of care that would occur when somebody is choking. And On Your Wishes, our local advanced care planning program, provides very good informational brochures, including about CPR, and so our project has provided both nursing homes that kind of written information, and both have found it really useful to have something written in very basic language, very accessible, but that explains some of these emotionally charged issues. One of the other nursing homes we're working with told us that they had the opportunity to engage a resident in a conversation when they were talking about, what kind of care would you like and what are your preferences, and this resident was very clear that he did not want to go to the hospital again. He did not want to be discharged to the hospital. He wanted to stay in the nursing home, and he was also very clear that he wanted to be a full code, so that if he would experience cardiac arrest in the nursing home, he wanted to have CPR attempted. And so the staff sat down with him and talked with him about, well, if you want to be a full code, then you need to be open to going to the hospital because that's how it's going to work here. And if you really, so understanding the connection between CPR and then hospitalization. And I'm going to turn it over to Nicole to talk a little bit about a situation that she experienced in a different city related to the IPOST. Please go ahead, Nicole.
We had another situation where a family member said, I do understand what my family member wants, I just disagree. And so it makes me think of a scenario in which I actually was involved with. I had a resident who was in the nursing home for rehabilitation following a stroke that had left her weak with speaking and swallowing difficulty. She previously lived alone in her home and was doing just fine. So frustrated by her current situation that when she began to realize how debilitated she was, she may not be able to turn back to her home independently, she became depressed. She participated in advanced care planning discussions with the nursing home social worker and did complete an IPOST. Her son, who lived far away and did not visit very often, was involved, so he was aware of what her wishes were and his role as the durable power of attorney. When I reviewed her wishes with her, she was able to tell me that she had never wanted to live this way, and she was comfortable with her choices for comfort nurse. Unfortunately, she did have another cerebrovascular event, and of course it was in the middle of the night. They called the son first, who said to send her to the hospital for treatment. I happened to be the nurse practitioner on call that night, and the nurse called and informed me of what was happening. Luckily, I was awake enough in the middle of the night to remind the nurse that this resident had an IPOST and her wishes were for comfort measures only and to not transfer her to the hospital. The nurse was able to discuss this with her son, who expressed that he was aware of his mother's wishes, but he was having difficulty accepting them. The health team was able to work with the son and express his feelings and remind him that as the durable power of attorney, his role is to make the health care decisions for his mother the way that she would want them, not the way that he wants them. In this situation, the IPOST actually gave a voice to the resident when she could not speak for herself. And then this resident actually passed away peacefully a few days later, which is what she had wanted.
Thank you for sharing that with us. questions that have come up as part of working with these two nursing homes are questions that they've encountered from their fellow staff members. And so through the experience of these two nursing homes, we're working with them to implement the POLST Paradigm. And then one of the nursing homes has a lot of subacute residents, well, actually both of them. And so they're wondering now, we're talking about engaging our residents with the POLST paradigm, but how about subacute residents? Is that appropriate or not? And then we had the discussions, and Jane reminded them about, well, if you think this person may die over the next 12 months or so, then yeah, that person is a candidate. But if they're not in that situation, then that's not what the POLST paradigm was set up for. Another one of the nursing homes we're working with has many residents who are not older adults, they're young adults, and many of them have mental illness. They're either suffering from the of a serious accident or they have mental illness, and so that brings up issues that are unique to working with that population as well, and we've met with the staff and talked through those things. In both nursing homes, as the other staff got more educated about IPOST, other questions came up. And so in one case, the activities director is saying, well, am I to bring the IPOST with me when I take 15 people to the casino, or 12 people down to the senior center, or 8 people out to the park? And so we walked through thinking this whole process through with the staff and realized, yes, the whole idea of IPOST is if somebody has an emergency and isn't able to communicate what they want, you know, what are other people supposed to do? And so the activities director helped develop the protocol in that particular nursing home that every time anybody left to go to the casino or to go to a doctor's appointment, if they had an IPOST, the IPOST went with them, and then the IPOST was returned when it came back. Now, it's not always worked smoothly. We're talking about the ideal here, but over time, and we'll be working with these both these nursing homes before the project is over. We'll be meeting with them monthly for a year. Over the time frame, then these routines get part of the culture there. I'd like to turn the microphone over to Jane now to talk a little bit about what these nursing homes are finding as they try to work with providers outside of their nursing home in terms of the IPOST, the paradigms. Jane, please go ahead.
Thanks, Mary. One of the most striking things that I have been reminded of is respectful of the roles of each individual within for people who are caring for the residents. So people, but also people within the care centers has a role in terms of IPOST. So though regarding other providers, as people, we all have relationships with different providers and they're all unique. And so we can't assume what one MD or what one licensed independent provider may want in terms of their involvement with IPOST. It may be quite different for a different provider. So I think it's beneficial to inform them if you're rolling out POLST in respective settings, to engage them, to let them know that you will be doing this, that you will be providing more comprehensive options for care for residents rather than just the DNR, CPR, or and what kind of involvement would they like to have in that? Jen, is that those discussions are continued with the DS coordinator and the social worker, director of nursing, et cetera, and then reviewed with the physician, for example. But upon that relationship that the healthcare provider has had with that specific resident, they want to continue discussions that they've already had, and we're respectful of the role that has already been established. So I think it's really important to talk about the process with other providers and what they like their role to be. And thank you. As we mentioned before, it's also just, a concern that I've had, even if people have gone through training, is well, other providers haven't, and to remind them that this is an important facilitated discussion and not checklist, and this doesn't work. if it's a checklist, it's not going to be effective. And the point is issued to verbal orders. In the state of Iowa, we can, nurses can have a verbal order. They can contact the physician or licensed independent provider and make that request. And the process of abnorm, getting the other signatures, et cetera, needs to be discussed so that it can be done in a timely manner, medical, since it is a medical order. Nurse, I'll hand back to you.
Thanks, Jane. We are wanting to be mindful that the goal of the POLST paradigm in general is that people get the amount and the type of care that they want. And as we're learning more about advanced care planning and about the POLST paradigm, this Kwai Maya Angelou comes to mind. At this point, I'm going to unmute Bob Conley's phone in case he wants to get in on the conversation, and then also check the chat box and the Q&A box. For those of you who were putting questions in the Q&A box, for some reason I'm not able to respond. So I've been reading your questions, but I haven't been able to respond. And some of you have been having issues with audio. And yes, we are recording this, and it'll be posted by Thursday noon on our website. And the handouts are available also on our website. I'm checking the chat box and see if there's any questions or comments. I don't see any, and there's no questions in the Q&A other than people reminding us that Nebraska is part of the POLST paradigm as well, and their forms are blue. And so does anybody have any other questions? I do that. Some people's hands are raised, but I don't. It's for us if you put it in the chat box, because unless your name is posted by a phone number, I don't know whose number is what. All right. So any questions or anything else, Jane or Nicole, that you would like to say, or Bob, any questions or points?
This is Jane. I saw in the Q&A box a question about hospice. So here, all of our hospice patients go through an IPOST facilitated discussion with our staff, and we consider that to be a standard of care for everyone. That applies for hospice.
Okay.
Another question, do I have any idea of how many nursing homes are using this right now? Nicole, you and Marie may have other responses, but it does vary from state to state, region to region, and that's we're a part of that whole paradigm in terms of the national standards and who fall for each of the designated levels. My meaning is for sure state, at least 50% of hospitals, nursing homes, hospices need to be using the POLST paradigm in order to be designated as the POLST mature state. So it varies.
Can these POLST forms be laminated? Seen any laminated ones?
And I recommend a plastic sleeve. I suppose it could be laminated. The reality is that sometimes people's preference change, and so you always want to work with the most updated document, and you destroy or void old documents. So I think it's I defer to your state regulation or recommendations regarding that.
Back of some POLST forms there's spaces where they've been updated. So if laminated, it would be hard to update it. Like, we had another conversation 4 months later, and then somebody signs that too. So I guess careful about it. But certainly the temptation to want to laminate them, because you want them to come back to the nursing home and you want to call attention to them, and they're very, very important documents, and lamination would convey that, but you still have to somehow attach it to the medical records or put it in someplace, and then you want to be able to refer to it and to it as needed. Are the forms that are in use in each state copyrighted, or are we able to use them? Address that?
Again, I would defer to your state recommendations or guidelines. We as individuals have the right to request to say what we want in terms of our healthcare preferences, whether it's a legal form or considered a legal form from a specific state, or whether we want to write out a narrative. According to the Self-Determination Act, we have the right to choose what we want in terms of our health care. So, although I would recommend that you follow your state guidelines in terms of the POLST form.
I also say that if you're working in a nursing home context, one of the beauties of the POLST form is that when that resident leaves the nursing home, the orders go with that resident. And so you yourself having a form isn't going to make the impact you be making if your community was using that form. And so you're in the state of Illinois, you don't want to be using West Virginia's form. You know, it's the system that respects the form, and that's one of the big differences between the POLST paradigm and advanced care directives in general, is that the POLST is a medical order, so that when a medical person encounters that POLST, they have a medical order of what to do or not do to that person. And an advanced directive can be very important and very helpful, but it's not a medical order. And so if you're going to be using this medical order, you want it something that is valid in your state. So yeah, the POLST forms are on the POLST website for different states. You can look at them. You can see not all the states use exactly the same language, and so you would want to look through there if you're trying to, if your state doesn't already have POLST. And we can go back to that map that Jane showed at the very beginning that let's get back there. I'm going from the middle, but of course I can't. Sorry. You get dizzy easily. Don't look at the screen. Okay, here we have it, POLST form, and so you can find your own state. Somebody's asking, hey, does New York have POLST? Yes, in New York it's not called POLST, it's called MOST, but yes, the state of New York has it. And the states can deviate from Oregon. Oregon's the first state that did this. They can deviate from their language a little bit, and some have. So it's important that if you are a health professional in a particular state, that you're using the form that the people in your state use. All right, so let's see. How can you ensure that the most recent document is always the one that's being used and that the one on file isn't outdated? Well, that's why there's been so much reliance on having one active form that goes with that person, whatever setting the person transfers to, so that you know that if you have that form, that's the most recent one. And if the resident or the person changes the form, to destroy the previous one. And that's why it's so important that that form stay with the person. Somebody have a question?
It depends on your protocol, or void it and just put the void. Some people then are required to scan that into their respective system, or EMR system.
They have to keep the voided ones?
Some do. Depends on the protocol of your respective organization. So this speaks to the broader question of that this is systems work. And it's also your responsibility when a person returns to once again review of the individual to make sure that they're updated, because they have changed. And changed in that in the hospital setting, for example, if they then return to a nursing home, their goals of care may change. And that's really what this is about, what they hope to receive in terms of medical care, and what do they hope to get out of the care that they are receiving.
important point that both of the nursing homes that we've been working with have encountered. When their residents return from the hospital, did that IPOST come back with them? And so the nursing home staff has been on the phone with people in the hospital saying, you know, where is that form, or let's get that form back, or when they send it, they have a little tag on the outside of the plastic sleeve that says, you know, what does it say exactly? I want to, Nicole or Jane, do you remember exactly the wording for that label? Must be returned or something like that?
Yeah, it says please return to, you know, the name of their facility upon transfer.
Oh, yeah, and so that's exactly what we're trying to prevent, is that people don't know if this is the most current one or not. So you want to keep what you're decided is the best way to make sure. Now, there's another question here. Megan asks, what would happen if a patient has an advance directive and POLST had contradictory wishes? Most recent document be what is used? Who'd like to take that question?
Well, I'll say this is Jane, and I would say that be careful with the question in terms of that. It's always best to review an advance directive and make sure it's updated, assuming that a person has decision-making capacity. In the state of Iowa, our laws specifically state that advance directive supersedes a POLST if contradictory wishes. So that is why it's so imperative that an advance directive be reviewed. And also the role of the durable power of attorney for health care. We want to engage that individual so that if the person cannot communicate, that that the wishes of the individual are honored, which is what should be on the POLST form.
Add to that?
I think that's answered very well. I'll go ahead and answer the next question, though. I see
Sure.
a person said, do you need a lawyer to sign the form? Nope. In Iowa, the form, because it is not a legal document, it's a medical order. In Iowa, it can be signed by a physician, a physician's assistant, or a nurse practitioner. It varies across states, so you will need to check with whatever your state's protocol is. There was also another question we skipped earlier about who can, there's a training required to do the IPOST. So our best practices is to use the facilitated discussion, and that is a program you go through and you become a certified facilitator. A licensed independent practitioner does not need to do that. So since PAs, NPs, that's part of your training to become licensed, so that's not required that you go to training. But for social workers and healthcare professionals, the best practice is to go through the training in Iowa.
About the pharmacy, do most POLST orders get to the pharmacy to reflect the monthly orders? Is physician orders needed?
I don't see that nursing homes here in our community are sending the IPOST to the pharmacy because that's an advance directive. It's not included as a medical order. I mean, it's not included as medication. So I don't think that is happening here. It's separate because it's an advance directive.
And I see Lisa says that in Pennsylvania, a photocopy of the POST form is just as valid as the original. And so the nursing home can keep the original and then send a photocopy to the hospital with the patient. From place to place a little bit, it's important to know what your local area has decided the protocol will be. Question you were going to get in?
First, I think this has been excellent, and the fact that you have a nurse social worker team is still important because one part is the medical and the medical order kind of implementation with medical staff, and the part is the team and the the social worker with the family, and et cetera. So that's great. I guess I'm not sure if I heard this right, but did someone, I believe it might have been Nicole, I was in the car, say that you surprised, the surprise question about a person dying, was that one of the that's part of this? Because that came up when I worked at CMS on the CARE tool, which was trying to use across settings. Is part of this, I hear the word surprise, but is it enough surprise that someone may die, or I might have heard that wrong.
Jane, I think it was your slide that mentioned that in front of folks now, it's slide 18.
Right. It's considered to be a clinical question to be used as a guide for when POLST discussion should occur. So,
yeah. And I think it's really important, Jane. I guess my question, like when we did some studies, we found that ICUs I think in one hospital, a study showed that 9% of the ICU were surprised that the person died. And are you finding that's used pretty often in homes, and that's people are comfortable answering that question?
Yes, I think in general, for people who are in long-term care, so those that aren't there for a short period of time, but meet the guidelines for being in long-term care and frail and elderly. And so they meet the guidelines for POLST Paradigm and the best practice. So that's what we are recommending in our community, that people transition from the DNR CPR order to IPOST order for all.
Yeah, nursing home, the kind of relationships that staff have with the residents in the nursing home would be very different than the ICU, because the nursing home folks know these people day in, day out, week in, week out, and they can have a better idea of what's normal for this person and also what the person's whole constellation of health challenges might be. And so they would be in a better position if they are trained to think this way, to would I be surprised if this person died in the next year? And if you would not be surprised, and that's not saying the person's going to, it's just saying it wouldn't surprise you, then that should get you thinking about different ways to meet this person's needs in terms of giving them the opportunity to talk about what it is that they might want to pursue or avoid in terms of care.
And then I have a follow-up question that's a little different. Your team of three, you're very available to facilities. How finding it seems like it's almost a culture change to use this form. How are you finding that the messages are getting down to the days, and how are you finding that these nursing homes will use it after you're not there to work with them so intensely? I guess, what's your sense of how the facility has embraced this process?
Well, I'm pretty confident they'll keep using it because it's so much easier for them. They can see that it leads to better care for the residents. So I think they're convinced. And it's a state law in Iowa that people can have a IPOST. You don't have to have one, but you are entitled to one. And through the process of getting over the challenges to make it part of the culture and part of the structure, to routinize it, I think that both facilities would say, yes, we should have been doing this, or we wish we would have been doing this earlier. We could have prevented a lot of misunderstandings, hurt feelings, and unnecessary duplication of care, or given people care that they wanted. Because the IPOST, and one of the questions is, what's the difference between POLST and IPOST? The POLST paradigm is the big picture, and how we implement that in Iowa we call IPOST, because it's part paradigm, but we've got some unique features to it. So POLST is the generic term, and IPOST is what we call it in Iowa. That's one of the questions too. But the issue then is that it's not just that form, but sitting down and having the conversation. So in the nursing home, somebody could say, the things you're telling me about what you want reflected on IPOST are very different than what's on your advanced directive. Let's have a conversation about that. Who else might you want to engage in this conversation? Who else needs to be informed? Who needs to be updated on your preferences? Think that. And in the IPOST, somebody could say, I want you to attempt CPR. I want to make sure that you attempt CPR. Because I have encountered nursing home residents who are afraid that people will think that they shouldn't be entitled to certain kinds of health care. They're afraid of ageism. And so those conversations are important. And if there's document is to clarify what the person would like, and they can say, yes, I do want this kind of care, or yes, I'd like to try to avoid this kind. And that's the whole purpose. That in the middle of the night or on the weekend or in a crisis, that people, the emergency responders and others know what kind of care does this person want. Through before we conclude our webinar to see if there's any questions that we haven't looked at. It looks like the final word's going to go to Deborah, and her question is, should we start doing paperwork during admission rather than the DNR paperwork? Nicole or Jane, do you want to let folks know what our two local nursing homes are doing?
Okay. Currently, in the facilities protocol, we have a few nursing homes nowadays that have a corporate entity, and whatever the corporate protocol is, that is what they must follow. So you have several places that are using the IPOST, and one of the things that they do on admission and upon transfers is that they go over if an IPOST exists, but if their corporate or their facility protocol says they have to use a separate form, they will still have whatever their facilities resuscitation form is in addition to the IPOST. So they have to be following their own protocol.
And I think,
go ahead, Jane.
You know, that some groups assess the situation and determine what the lay member or individual is taking in and to what type of conversation they have. They may introduce it and then follow up a year or two later or a week later, but at least they have to get the DNR CPR order and then they transition to an IPOST. What we're hoping in terms of the culture shift is eventually when people go to a nursing home, they may already have an IPOST on admission, and so then it would just be reviewed as a part of it.
That's a good point, Jane. As a society, we are expecting so much out of nursing homes because we're not talking about these issues outside of nursing homes as much as we should, and so a lot of the onus goes on the nursing home itself. The nursing homes in our study the seed at admission and says over the next 10 days we'll have somebody meet with you to tell you about IPOST and then decide if this is something for you. I should also say that when both of the facilities in our study started with IPOST, they didn't start with new admissions at all. They're going through and talking to the people that they think are going to be the easiest to talk with and, you know, the low-hanging fruit, and they're building their skills that way, and they're building their own familiarity. They also went through the training to have these facilitated conversations. And so if you're going to go through the whole IPOST conversation, I don't think you're going to do that on admission day because it's overwhelming for people. They're already signing so many other things. But you could certainly let people know that they have the opportunity for an IPOST if they would like, and then pick that up a little bit later and follow through with it. I've reached the end of our time. Please know that we're available by email as well, and many of you are on the listserv, and you can put any questions to the listserv too, and we will address those questions. And I want to thank everybody for your time and your attention, And thank you for all the good work that you do every day with nursing home residents, families, and fellow staff members. Thank you, Jane and Nicole.
Thank